Assalamu alaikum everyone. Welcome to another episode of our Beyond the Stethoscope webinar series, Flatlines and Lifelines. My name is Maria Fayoumi, Director of the Internal Medicine Interest Group, and I'll be your moderator for today's session. On behalf of IMIG and the Medicine Club, it's my pleasure to warmly welcome you all and to extend a special welcome to our guest speaker, Dr. Bara AlMakadma. Dr. Bara AlMakadma is a consultant internist, adult cardiologist, and advanced echocardiography with a special interest and training in business administration and in data science and artificial intelligence. He holds an MBA in healthcare management and a postgraduate degree in AI and machine learning business application. He is also an adjunct assistant professor of medicine. We're truly honored to have him with us today, and we look forward to an insightful and engaging session. Dr. Bara, the mic is yours. تفضل.
Thank you very much for the invitation. The idea of this presentation is to try to tailor and describe what cardiology is and what it would look like should you choose to pursue a career in it, and what is the path to get there, and what kind of skill set would be necessary to make the journey. The title Flatlines and Lifelines was suggested by the group, which I like. I only add to it navigating modern cardiology. The agenda for today is to, first of all, have a lot of reflections about our specialty. So I'm going to do an open reflection on why choosing the heart. And I'd like to talk about gravity and impact as a principle when it comes to decision making, as to how you would make large decisions where you invest large time or amounts of money. There is a confusion matrix where a lot of gravity and impact to little gravity and impact in relation to how much time and effort can be put in a certain prospect that would help you kind of make a decision. You'll see what I mean shortly. Then I'll talk about core roles in cardiology in the modern landscape, because cardiology is no longer a subspecialty in the sense that a lot of people think that it is. In fact, it is yet another level of general specialty where you have to then choose a certain path, whether through formal training or through the choices you make into how you're going to go ahead and practice. And then we're going to talk about mapping those paths and then choosing the correct kind of approach to which clinical foundation and subspecialty you're going to get into. And at the end, I'm going to conclude with the tech frontier and how how current things are going to affect our ability to make choices, and how is it going to affect our career prospects in the future. So much as far as we know today, because a lot of things are changing. So let's start with a little bit of reflection. Choosing cardiology. So it's a field where there is a lot of, it's very robust. There's a lot of research, and it is at the cutting edge of technology. In fact, it's probably the most technologically advanced field in all of the fields of medicine in terms of how much research and how much has been spent into it. And then there is the idea of how much work you actually put into it, and how much effort you have to put into it, and how much how mindful you have to be on everyday basis so that you can perform at the level of cardiologist and still be safe, and then still manage to balance between your life and your life's goals, and your ability to perform good work. In short, cardiology demands more than one would think when it comes to other careers that's outside of medicine. And then within medicine, it is one of the more demanding ones. And as we were talking about internal medicine, and this group is for internal medicine, it's an internal medicine interest group. Cardiology is probably amongst the ones that are slightly more demanding because of the sense of urgency that is included. And so let's go ahead and choose and look at the choice for cardiology, and why, for example, I would choose cardiology. So for me, the choice of cardiology was not very planned. It was rather organic. I started off wanting to be a neurologist, and through my internal medicine training, as I was in R2, I realized that there's a lot of satisfaction. So we just talked about a lot of work and a lot of robustness and putting in a lot of effort, physical and mental, but the satisfaction is also very high. When you're working in the emergency room at night and you're getting a lot of people coming in with heart attacks and you're able to appropriately pick up on all the different data you see here and pick up the appropriate diagnosis, realize this is probably an ST elevation myocardial infarction, perform the correct activations and sequence, the cascaded sequence of alerting the correct medical staff, activating the cath lab, and informing the patient, explaining to them while they're in pain and in a state of need, and reassuring them while at the same time not over reassuring them so that you don't take away from the importance of the decision that they're going to make when they consent to the procedure, so that it has to be informed and ethically so. And then proceed to shifting the patient and doing all the little intricacies that come with that. The hierarchy in medicine is very much real. You would have your interns do a certain task. You would be doing something for your senior, and the senior would be talking to the specialist, and the specialist would have alerted the interventional consultant and would have also alerted the consultant on call if it is someone else. And that all needs to happen very smoothly while you bring in technicians from home, you open up the cath lab, make sure the equipment is running properly, do the timeout, which means all the equipments are laid out and you're ready to perform a procedure that within which it is not a procedure that is just a step-by-step thing that you do with every patient, such as, for example, a simple appendectomy without prior surgery. It is a diagnostic. There is data. So cardiology relies on the clinical aspect as well as on realizing that 51 to 52% of cardiology is based on clinical data. So those would be the imaging, the different multimodality imagings of the heart. So the cardiac CT could have been done in triaging in the emergency room if it was a non-STEMI, and you'd want to know whether it is safe to discharge the patient home or not. The ECG, of course, and you'd want to know its limitations and its calibration. The echocardiography is probably, and maybe I didn't say it first so that I'm not biased because I'm an echocardiographer myself. And of course, you'd want to link all of that data, including a lot of other things like nuclear imaging, cardiac MRI, stress cardiac MRI, stress dobutamine echo, stress echocardiography, the ECG, computerized treadmill stress test. These are all different aspects that have to be integrated, and each one of them has a weakness and a difficulty, and every one of those cardiac data modalities are ones that can be specialized in down the line now in the 2020s. So let's go back to that patient in the cath lab. You're not doing a simple, straightforward one step then the other kind of procedure, step-by-step procedure. You're actually recognizing this is an occlusive myocardial infarction and it is an emergency, but you're also going to perform the diagnostic where you're going to inject the right and left coronaries and then decide how severe the disease is. And when you don't have time, we don't have time to do that kind of thing. You need to realize that you have to suspect which artery is your culprit based on the data prior to the cath lab. So you have to do a clinical judgment as to which coronary you're going to inject in first, hoping to save the life of the patient faster, and then diagnose the other. So let's assume you correctly identified it's a right coronary. Yes, you can do that. Prior to taking the patient to the cath lab, you look at an ECG. The different leads are taken from different locations in the heart, and you would realize that this is probably related to that location, and that location in the heart is, say, supplied by the left circumflex. And so you enter the cath lab, correctly identify that the occlusion is there, open it up, and now you don't leave prior to finishing your diagnostic and realizing, okay, I have other diseases in the other coronaries. Do I fix them now or do I wait? And then you enter into a further diagnostic modality. I'm just taking you into a journey of what it would look like. to be an interventional cardiologist. How about a non-interventional cardiologist? Well, you still see your fair share of procedures, that's for sure. And you're still sometimes called up at night. It depends on the level and size of center you want to work in. And that is another decision that you'd want to also try to learn about so that you can make the correct decision. And so you could be woken up as an advanced echocardiographer for an emergency valve surgery, and you're going to go ahead and scrub into the OR with a cardiac surgeon and put a probe in the mouth of the patient into their esophagus. We call that the endoesophageal intubation. And then you'd want to look at the hemodynamics of the heart. And you'll do a little bit of physics and a little bit of hemodynamics, a little bit of pressure measurements and some flows and velocities, and that would determine whether a valve is seated well and whether the surgeon is okay to, for example, close up a valve repair surgery, because you're going to have to determine that it's okay. And prior to suturing everything back together, maybe some inotropes would be given to overcome the effect of anesthesia and improve flow. And then you test with the probe what it would look like for blood to start flowing again through the repaired valve. And mind you, in cardiac surgery, the heart is frozen and the blood is pumped through a bypass machine. So by the end of the surgery, as everything is turned back on, so to speak, it is important to be sure that you're going to have to close, or you're able to close safely. One of the other use cases of this modality is to actually prove and document by imaging and real data and real numbers that the surgery was successful, and that would kind of protect the team afterwards. If anything happens, you know that this happened after, and that would help, and it would protect the team in the diagnostic sense, that it would help you diagnose in a temporal manner when one thing happened versus the other. So this is a specialty that never stands still, and it basically goes all the way from a patient crisis into a long-term trust. And so the long-term aspect, I took you through some of the acuities of it, right? The long-term aspect would be, and I'll give you the last acute case and show you how it would turn into a long-term. You get this old man, an 80-year-old grandpa, coming in with all his beloved ones, who can no longer breathe normally and is feeling very dizzy. And you find that he has a condition called a sick sinus syndrome, where the heart is very slow and the pacemaker isn't working well. And so in the middle of the night, the emergency room will call the electrophysiologist, who comes in and might implant a pacemaker for the patient. Pacemakers range in different types. There are temporary ones and there are permanent ones. Regardless, most of cardiac diagnoses are for life, and patients will continue to follow up once there is a diagnosis of importance, such as an electrical arrhythmia or a heart failure or a coronary heart disease. And so the longitudinal follow-up, and while the USPSTF and other organizations, including safety centers and patient associations and medical associations and councils across the world, including different health systems and institutes, will have guidelines on how to prevent from a primary perspective, primary prevention. We also, as cardiologists, look at secondary prevention, because someone who has had a heart attack is more likely to get another heart attack. And that is something that is grave. There is a lot of importance in preventing another crisis of such nature. And so the long-term aspect would be to try to preserve what you have done so far and protect an incident, a crisis, from occurring again. And of course, to try to improve the life quality of the patient by cutting edge medications. On the frontier, there's a lot of research and a lot of pharmaceutical research as well. And we're integrating a lot of different primary preventions. In 2026, just now, we had the new lipidemia guidelines released by the ACC. And in it, there is emphasis on glycosylated hemoglobin and lifestyle and smoking, and as well as aggregating the blood sugars and looking into ethnicities and backgrounds and other risks to try to modify all the modifiable risk factors. So there's there's a lot of robustness in it, even on the everyday clinic. So there's a lot of patient care. But more importantly, the long-term trust is not only in the clinic, it's actually telemetric. A lot of cardiology is done by telemetry. You would be sitting at home this morning, as a matter of fact. I was reading 24-hour recordings while I was in a restaurant with family and making patient decisions and sending those decisions through the electronic medical record. And so that's something that a cardiologist would also do that might be slightly different from other specialties where you're on the go, but you're still connected to your patients. We have patients, for instance, who have implanted pulmonary artery pressure monitors. And that means once the pressure starts to rise, that's the early sign of pulmonary edema, then we can recognize that a heart failure is about to happen prior, an acute decompensation of heart failure, that is, prior to even the patient themselves might sense. And we would call the patients and tell them to increase their diuresis, and that would also potentially save at least hospitalizations, sick days, and even possibly lives. So, flatlines versus lifeline, there is a balance. Let's talk about this kind of confusion matrix. We have a lot of high gravity diagnoses and high gravity critical situations and interventions, and they are of high impact, such as the three scenarios I gave you. There are also low gravity situations, but with high impact. All the those would be all the diagnostics that would happen outside of the acute settings in terms of the multimodality, non-invasive and invasive diagnostics. So a cardiac MRI, a stress test, and we have a bunch of stress tests where the patient cannot exercise, but we can still do them, such as the nuclear stress test with stress and test phases, and we'd get their ECG stress with a substance that speeds up the heart chemically, and then we would take nuclear imaging of the cardiac perfusion using different modalities such as thallium infusion. And then we also have things like the dobutamine stress test, where you'd give dobutamine, increase the heart rate, and then you'd look at the heart walls by echocardiography. The heart is actually divided into 14 different segments, and each segment, into 17 different segments, sorry. In each segment, we know which blood supplies, which is the most likely blood supply for that one out of 17 segments. And by knowing the state at rest and which segments move well, even in patients who have already had old MIs, when we compare meticulously segment by segment after dobutamine infusion and raising the heart to the maximum predicted for age, even in a patient who cannot walk, someone with severe osteoarthritis, and especially those old of age, we can determine their cardiac reserve and fitness for further invasive treatments, such as someone who needs a hip replacement, has had a heart attack before, but the orthopedic surgeon is afraid that maybe the heart can't take it. So we can use all of those modalities. So they have high impact, even though the clinical scenario is relatively controlled, so it's low gravity. We have the high gravity, low impact, and those are a lot. Those are not uncommon. We have all the kinds of consults you get at night, and the messages you have to like communicate, and referrals you have to accept, and the nurses calling you, and you're not allowed as a cardiologist not to respond instantly. One of the interesting comments I heard from our internal medicine residents a while back in the university was, you cardiologists are a bit tough. You're very tough. And I thought, well, no wonder. There's an American study that stated in every major hospital, in every community hospital, at least 42% of the total hospital traffic will pass by the cardiologist every month, because everyone will be afraid that the heart is sick. If it's tachycardia, they're going to call. If it's bradycardia, they're going to call. If it's hypertension, they're going to call. If it's hypotension, they're going to call. If it's a palpitation, they're going to call. If it's an enzyme up or down, they're going to call. And because they don't want to bear the risk of making the decision alone without actually consulting with a cardiologist first. So those are the high gravity, low impact. Then there are low gravity, low impact. Those are the routine tasks. You're writing up notes and reports for patients who are otherwise stable. They take a lot of time and they are redundant and they are a lot. And I'm hoping that the advancing technology and maybe the prospect of machine learning and codified cardiac sciences would help decrease some of that workload that is otherwise just consuming time that could be spent in a better manner. The midnight calls and the idea of needing an always awake mind is something that you cannot go without in cardiology. There are many specialties in internal medicine where you can have, once you've done all of your training, you can have sound nights of sleep. We don't. And so if you want to be in cardiology, you have to know that you're doing this and that you're technically protecting your society. And in Arabic, I believe that you are مرابط على ثغر من ثغور المسلمين. And I think this is a wonderful, ethically accurate way to look at your role. واحتساب النية is something that's absolutely necessary. And so you have to be always, your brain has to always not only recognize the critical warnings, such as a flat line, and not only conjure the rapid response protocol, such as ACLS, and having an idea of what cues to look for, you have to also be able to predict those things before they happen just by hearing the clinical scenario, especially if you're being called from home and guiding a junior medical colleague. So there are core roles in cardiology. I think I've outlined them in the stories that I've given, but I'm just going to go ahead and now formally kind of divide the larger aspects of cardiology into there are core responsibilities that any general cardiologist will have to know. And I kind of insist in every slide that you have to comply with the guidelines. So to us, guidelines are a big deal. So you have to diagnose, manage the cardiovascular disease using non-invasive tests and then apply guideline-directed therapy, be able to look at the different medications and optimize them and do the appropriate referrals to other cardiologists who do, for example, multimodality imaging, invasive and other non-invasive work, or electrophysiology. And you'd have to know the workflow steps. So non-invasive cardiologist would be the first role. And this one would be the general cardiologist, the multimodality imager, and classically the advanced echocardiographer. And there are other specialties as well. So you have cardio-oncology, you have cardiac heart failure, you have cardiac sports medicine, and many more in today's field, which is really cool. And then you have advanced echocardiographer as a role and skill set. So this is a classic subspecialty from cardiology. And the reason why I use the word classic is because it's one of the older ones that have existed for a while, but it's one of the core data acquisition modalities. In a day, a community hospital would do some like 60 to 80 echoes every single day, and it would influence a lot of diagnostic decisions for the patients because it is a rapid, an echocardiography could be as rapid as 1,000 hertz if it's done in an M mode, and it could be, and it's something that's done live, and it is non-invasive to a large degree. It doesn't even have radiation. It can be done on a pregnant woman. It can be done in the ICU. It can be done portable. It can be done in a lot of different ways. And so you have that. And in today, we have advanced skill sets and we have subspecialties from echocardiography. So you have the structural echocardiography, for example, as a separate field. And you have people who are now specializing in 3D echo and strain imaging, which are techniques that will track specific speckles of the heart or build 3D images of the heart. And the reason why that's important is because you can reconstruct a clinical image and come up with a clinical diagnosis that would have otherwise been more difficult. And it would answer things about viability and about cardiac structures and would even influence decisions for surgery and surgical preparation. And then there's the invasive cardiologist. So that would be the cath lab interventionist. And this is obviously potentially the coolest one of them all. This is the one who comes in the middle of the night every day and opening up clogged heart vessels. And the famous or the cool aspect of what an interventional cardiologist would do is the thing that I described in the beginning of the presentation, that whole scenario of ST elevation and activating primary intervention and going to the cath lab and doing that whole thing. But the interventional cardiologist does a lot more than that. So there are also many subspecialties from interventional cardiology. It's not only the coronaries, we now do a lot of structural interventions. So you have the structural interventionist, and some of them will be specialized in specific valves, and some of them will do even further procedures. So you can do a transcatheter aortic valve implantation, you can do a transcatheter mitral valve implantation. Even though the mitral valve is quite big, it's not a small valve, then you can still do that. You can do transcatheter, that means through the cath lab, through the wires and tubes. You can do things like fixing a severe valve leak by putting a clip on it. You can even, for example, close the left atrial appendage in someone who cannot tolerate anticoagulation and would need to close that to prevent strokes in an atrial fibrillation patient, for example, and who's otherwise having bleeding risk. And so there are many things. And some of the cardiac interventionists also simultaneously specialize in vascular intervention. And some of them will specialize also in pulmonary vascular intervention as a specific kind of intervention. It depends on what you want to do and where precisely you want to do that as well. The invasive cardiologist will do one further very important role, which is the right heart catheterization. Now, this is the time when they go in the veins, not the arteries, and they're measuring pressures and flows, not injecting contrasts and opening up clogged vessels. And that helps significantly in the diagnosis of cardiac shunts, abnormal flow states, and classically pulmonary hypertension in its subtypes. There are many subtypes of pulmonary hypertension, and that influences the kind of decision that a cardiologist will then take about what and how to treat. And then, of course, there's the electrophysiology cardiologist. So another career curveball that I've had, I've always wanted to be an electrophysiologist since I knew I wanted to be a cardiologist, but then things didn't work out the way I wanted it, and I'm very, very lucky and happy to be precisely where I am today, but I still have tremendous respect and love for the electrophysiology doctors. So these doctors are the ones that will save your heart from an electrical abnormality. If your electrical conduction system does not work, they can not only fix it, or, for example, ablate an abnormal rhythm circuit by doing 3D mapping of the heart. They can even implant a whole implantable cardiac devices. So the electrophysiology cardiologist is an advanced clinician with a lot of critical thinking mindset. They do longer training, and their interventions also take much longer, especially if they involve mapping. So they can take a lot of hours and a lot of patients and to perform the correct kind of diagnostic. And then one of the probably faster interventions or procedures they do is implanting the implantable cardiac devices, but based on correct clinical diagnosis. So they have to make the correct diagnosis, comply with guidelines, and know precisely what type of device would be appropriate now. And sometimes they'd have to future-proof their patient by putting a device that the patient might need, would function now with one function and can be reprogrammed to another function. So yes, technically, we're implanting small, little, very advanced computers into patients' heart, but then the electrophysiologist outside of the cath lab does a lot of treatment choices, medication choices, helps in the intensive care unit, does a lot of longitudinal follow-up with patients with arrhythmias, with frequent medication reconciliation, and would also do a lot of preventive device implantations for heart failure patients. So the heart failure non-invasive cardiologist, which is a specialized service, by the way, would send a patient for primary protection against an arrhythmia based on advanced diagnostic of that issue. Is that all? Absolutely not. There is one further step, which is running the device clinic. A lot of patients have device clinics, and you'd have advanced technicians who are well trained into interrogating and realizing what these devices do and how they're programmed from the get-go, and then reprogramming them properly so that they are reactive to the patient's own life. So someone who couldn't walk, then did a lot of physiotherapy and then improved from a stroke, had a cardiac device programmed one way, and now they decided to do rehabilitation or even exercise. We can reprogram it into an adaptive mode that would mimic the heart, sense motion, realize when the patient is exercising, and then exercise. And we can program the devices also to adapt to sleep-wake cycle and things that would try to mimic physiology. So this is also a very advanced field that uses very expensive tools to save lives. When the correct tools are available in electrophysiology and the correct diagnosis is made, one can argue, and this is how I'm selling electrophysiology for anyone who's interested, you can argue, for anyone who's interested, you can argue that in today's day and age, no one should die from a cardiac electrical problem if it's correctly diagnosed. So yes, today in 2020s and beyond, modern cardiology landscape has become a little bit complicated, but it's become cooler than before. It is very objective, and it not only relies on properly diagnosing and treating, but it also now relies on predicting risk earlier and tailoring the therapy specifically for every patient in a way that would improve their specific outcome. So there's a lot of context to the different patients, but I'd like to look locally that we have a lot of specialized centers of excellence in Saudi. And I also want to emphasize, since I referred to the guidelines a few times, that we're now developing our own Saudi Heart Association guidelines, and I think those would play a heavier role. I'm very excited about them. And those things do matter because tracking the shifts and how they happen, this kind of history of medicine, clarifies collaborative pathways between each other and would help us improve patient outcomes. So a little bit of insight is modern cardiologists must continuously adapt to changing patient demographics and changing data and emerging technologies. You want to emphasize it's absolutely important to know that in cardiology, we do not think like a lot of other specialties. And I'm very proud to say this because it's not, and it's contrary to what you might think. It's not like, oh, we're better than others. No, we actually emphasize not to make decisions alone. We emphasize multidisciplinary collaboration. And in our guidelines, when we want to make an actual decision into an intervention that is complex, you have to have something that we call a heart team meeting. And those are usually done once or twice a week. That would include cardiac surgeons and interventionists and non-interventionists. And so there's this emphasis on cultivating multidisciplinary action, and of course, embracing innovations and different technologies that would ensure that we can maintain high quality care while meeting all those evolving aspects that we talked about, from societal to clinical demands to patient demographics to technologies. One note that I will highlight that I really found to be very true for me is that the cardiologist in training is trained to think more in more dimensions than ever before. Sorry about the typo, than ever before. And it's not just critically and empathically, but also strategically. So your brain will open up different horizons and you'd likely become a different person. A lot of people ask, especially those who pursue training in the US or so, you're going to be paid very similarly as a staff physician or a consultant physician. But the truth is, your thinking process would be different. The kind of stimulation, mental stimulation you'd have is different. And so if that is something that matters to you, if you never want to be bored, I think cardiology is possibly a good choice. So mapping up career pathways, this is just to summarize everything that we've spoken so that I can slowly come to opening the floor for questions, is that clinical cardiology is a generalist foundation that has a lot of cardiac data, different specialties, and a lot of coordination. And as we said, data is a huge aspect in cardiology. Learning them is important as to presenting their interpretation, as it is as important as history and clinical examination. There are different subspecialties, but the large ones are the cardiac imaging, the electrophysiology, and the interventions. So the plumbers, the electricians, and the architects. And I absolutely love this. I always tell my patients in the clinic, المقاول والكهربائي والسباك. And so it's like we have this kind of project that we're working on together. And cardiology has shifted in a lot of ways. It's no longer uniform training. Some centers are more specialized in other aspects. And so even when you start your general training, you would be more inclined to subspecialize. And the more exposure you have, the better. I argue as a cardiologist, you'll continue to learn for life. Let's talk about the future. So now, if we talk about reaching 2026, the future is now holding obviously AI and machine learning. To us, this is helping me, for example, every day into performing complex echocardiography, quickly rendering 3D images, quickly doing strain echocardiography that in the past would have taken slightly longer. It's already implemented, it's already in the guidelines, it's already in our machines, and it's already being used every day. And this is only the tip of the iceberg. ECGs are being interpreted, and clinical flags and alerts are being written and sent using AI ECG machines. And of course, this overall, the reason why this is important, and when I say the tip of the iceberg, is because when it comes to AI, it's all about data analysis and data aggregation, but not only doing simple data analysis, but actually being able to execute proper flags and having real dashboards with real KPIs that integrate all of that different data along with real-time data about the patients, the situations, the staffing of the hospital. So there's a strong argument even administratively, and it would arguably allow us to treat more patients with this level of high gravity situation, and we can treat a much larger patients without having to be burnt out as much. Technology can inform, but only the physician can truly care, guiding every decision with wisdom, empathy, and experience. This quote is important, and interestingly, it was generated by an AI engine. In conclusion, innovation with compassion and a lot of highly rewarding hard work will actually be something that you will see if you do cardiology. But I argue if you continue to do whatever field of medicine that you do, I argue that you have to look to make an impact with responsibility, embrace technology as an enabler, and learn its ins and outs and being ethical about it, trying to be a healer and innovator, and empathy remains the center of medicine. Once we lose empathy, I think we lose everything. So that's the end of my presentation. Thank you for attending, and the floor is now open to you for questions and comments.